Chapter 10 is the shoulder joint. It is a ball and socket joint with the humeral head articulating with the glenoid fossa of the scapula. It has movement in all three planes around all three axes. It is the most movable joint in the body, but it is also one of the least stable joints in the body. Remember that dysfunctions in the shoulder girdle joint can play a direct effect in dysfunctions in the shoulder joint and vice versa. This is a review of the scapular landmarks that you need to know for different attachments for muscles and ligaments. But remember that the scapula is also not directly correlated to the ribs, but it does glide above the ribs. Here are some different attachments, or attachment points on the scapula. And to finish it out, under the vertebral border there for the H, you can also include that the rhomboids are attached there as well. The vertebral border is also approximately about 2 to 3 inches from the spinous processes in your thoracic vertebrae. Alright, here is the glenoid labrum. It is a fibrous tissue surrounding the glenoid fossa, and it deepens the articular cavity. There are a lot of labral tears that can occur, usually with a traumatic injury, but not all the time. It's also usually involved with the biceps tendon. As you can see, if you look on this picture here, where G is, this is the biceps tendon that actually come up and attaches. So damage to this area is usually where a lot of labral tears can occur. Most of the time they require surgery to repair. Alright, so here are some humeral landmarks. Again, these will serve as attachment points for muscles and ligaments that you will need to know. Here's some other ones. An interesting note for the bicipital or intertubercular groove is this is where a lot of people can get things like something called bicipital tendonitis, because the biceps tendon actually runs right through this groove here where the letter H is, and the ligament that crosses here, when it does not hold the head in there, it can cause damage to that tendon and a lot of pain. It can be common in people like people who like to swim or row, even weightlifters, golfers. Those kind of activities can irritate the biceps tendon there. Alright, here are the joint motions in the sagittal plane around the frontal axis. You need to memorize each motion that we're about to go over, plus the degrees of motion available and what plane and axis it evolves around. So again, here are the sagittal plane frontal axis motions. You have flexion that goes from 0 to 180 degrees. Extension is just neutral. And then hyperextension goes from 0 to 60 degrees. These are the motions in the frontal plane around the sagittal axis. You have abduction, which is 0 to 180 degrees, and your humerus must be in external rotation. So in standing, if you're standing in neutral, your thumb must be pointed out laterally to go all the way up to 180 degrees. Adduction is the other one, or bringing it back down into neutral there. So again, it must be an external rotation to get that abduction. Alright, and these are the motions in the transverse plane around the vertical axis. You have external rotation, which is also called lateral rotation. You have internal rotation, which is also called medial rotation. You have horizontal abduction and horizontal adduction. Alright, the shoulder joint has a joint capsule. It's a synovial joint. The joint capsule itself is thin-walled, but has a lot of space within it. It attaches around the rim of the glenoid fossa of the scapula and the anatomical neck of the humerus. It has an outer fibrous membrane and an inner synovial membrane. And it's taut or slight, so it's taut with the arm hanging at the side. Superior portion is taut anyway, and the shoulder abducted, the inferior side is taut. And kind of here's a good picture of that All right, so we move on to the ligaments of the shoulder joint. Some of these are review from the previous chapter of shoulder girdle, but they play a big role in the shoulder joint as well. So this is the coracohumeral ligament, and it attaches the lateral side of the coracoid process, the medial side of the greater tubercle, and it strengthens the upper part of the joint capsule. So you can see that it sits on the top side here. If I can get my mouse to work, there we go. Sits on the top side, strengthens the upper part of this capsule here. Glenohumeral ligaments, so the series of 3 right here, because there's a superior, middle, and inferior one. They're not super well defined, and they're kind of actually pleated folds of the capsule right here, but they reinforce the anterior portion of the capsule. You have several bursa throughout the shoulder that help to kind of cushion where there can be a lot of friction, since there is a ton of movement in the shoulder available. The couple that you will need to know are the subdeltoid bursa. It's large and it's located between the deltoid muscle and the joint capsule, and the subacromial bursa, which lies below the acromion and the coracoacromial ligament, between them and the joint capsule. It's frequently continuous with the subdeltoid bursa. People who have surgery to help widen the gap for shoulder injuries and stuff like this, a lot of times they will just remove this bursa, or one or more of these bursas here, to alleviate pain in the shoulder. Alright, the rotator cuff here, which this is not a great picture, but it is a tendinous band formed by the insertions of supraspinatus, infraspinatus, teres minor, and subscapularis. Easy way to remember that is if you take the first letter in all 4 of those, it makes the word sits. And that's kind of a good way to memorize the rotator cuff group. Their job, and remember this, is to help keep the head of the humerus rotating against the glenoid fossa. Rotator cuff, parts of the rotator cuff are easily injured and can be injured often, and sometimes repaired with surgery. A lot of repetitive motion that involves internal and external rotation is what can actually damage parts of the rotator cuff as well, especially if there's not adequate strength in adjacent muscles. So here's kind of an anterior view of the shoulder joint. Note that the letter F here is the biceps tendon, okay? The long head of the biceps tendon, which wraps around like this. And you can see how it's being held in place by the ligaments. It comes over the top portion there. Here's the posterior side of the shoulder joint. Keep in mind that letter C there is the coracohumeral ligament. It strengthens the upper portion. D here is the supraspinatus. E is the infraspinatus. F is teres minor. G is the triceps, long head of the triceps. And H itself is the capsule. Alright, so here's a lateral view of the shoulder. You can again see all the difference. So again, there's the biceps tendon that comes through there. And it actually attaches, a portion of it actually attaches to the top part of that labrum right there. Alright, the thoracolumbar fascia is a superficial fibrous sheet that attaches to the spinous processes of the lower thoracic and lumbar vertebrae, the supraspinal ligament, and the posterior part of the iliac crest. It covers the sacrospinalis muscle and provides as a broad attachment for the lats. A good picture of it is on figure 1019 on page 141 in your textbook. Alright, so shoulder stability is comprised of these things: the glenoid labrum, glenoid fossa anterior, lateral, and upward directions, Upward direction provides some stability. The joint capsule is reinforced by the coracohumeral and glenohumeral ligaments. The capsule completely surrounds the fossa, kind of creating a partial vacuum. The rotator cuff muscles and the shoulder muscles all help to stabilize. We're going to start into the shoulder muscles here, starting with the deltoid. Again, it's going to be your job to remember the origin, insertion, nerve, innervation, and action of each one of these muscles we go over, as you see them on tests and quizzes and so on and so forth. Quick note about the deltoids hill. The deltoids can take up for the majority of motion for injured rotator cuff muscles. So a lot of times people can have a damaged rotator cuff group or a particular muscle in there, but not realize it because the deltoids are not injured and are strong. The biceps muscle can also take over and is usually overworked if part of the rotator cuff is torn for things like flexion. Hence that you'll also find in patients that have rotator cuff injuries or tears, their biceps tendon and deltoids can also be knotted up or very sore and overworked. Keep in mind that the deltoid is the superficial muscle, obviously, but it has 3 sides, and all 3 different parts do different motions. All 3 of them share the motion of abduction, but the anterior fibers and middle fibers and posterior fibers also do several different little things, as you can see at the bottom of the slide here. Compare these to what the rotator cuff itself does. The supraspinatus muscle does abduction. Infraspinatus muscle does external rotation and horizontal abduction. Teres minor does external rotation and horizontal abduction. And subscapularis does internal rotation. So keep in mind to compare what the rotator cuff muscles do along with the deltoids, as it can help when you train patients recovering from associated injuries. We begin part of the rotator cuff with the supraspinatus muscle. It is the one of the most common injured rotator cuff muscles, and a lot of times it can be from overuse injuries and lack of strength, but it also can happen obviously because of traumatic events. Pectoralis major. There's 2 portions that you'll need to know this, the clavicle portion and the sternal portion. And you can see, again, keep in mind, especially starting with back at the deltoids, is keep in mind, watch the line of pull for each one of these muscles here. And at the end, you will be able to see that the shoulder has a lot of motion, obviously. So it doesn't take much that when you injure something, it can have an effect on a lot of adjacent muscles. All right, latissimus dorsi. Again, remember that it also kind of attaches to the dorsolumbar fascia. Teres major, which is also known as the little helper of the latissimus dorsi. Infraspinatus is the top portion here, the letter A. B here is the teres minor. And in a note about the long head of the triceps here, the long head of the triceps, as you can see, it's just this A, this nice long one right here, helps to divide teres major and teres minor at the axilla. Subscapularis sits on the anterior side of your shoulder blade, so remember that this is the anterior side, not the posterior side. And you can see its line of pull creates that internal rotation here. So here's a superior view of the rotator cuff. Note that the supraspinatus, infraspinatus, teres minor, subscapularis are all in line, and these are the 4 muscles that make up the rotator cuff. You can check out page 139 in your book for a better or a colored picture of this one as well to kind of help you better illustrate that. And then we have the coracobrachialis, and its main function is just a stabilization of the shoulder joint. All right, here's the summary of the prime movers of the shoulder joint. And then here's the summary of the innervation of the muscles and what nerves. Going back to this prime movers of the shoulder joint, I can't stress enough that keep in mind the scapular muscles, the shoulder girdle muscles that we went over in the previous chapter, play a very big, important role in how the muscles in the shoulder joint function as well. And that concludes